Hello, my name is Tillie Schumann, and I will be presenting on a case report of heterotopic pregnancies in atypical locations, including a corneal and ovarian presentation. And I'm from Kansas City University. Overall, for this, the rationale is that heterotopic pregnancy is a difficult clinical picture because of early on in pregnancy, you have a pregnancy of unknown location. Sometimes it's hard to discern with a rising HCG whether that is an intrauterine pregnancy or ectopic, or in the case of heterotopic, it's defined as both of those concurrently. And it is relatively uncommon, so a lot of practitioners might have not encountered it before. It's something they're aware of, but they might not have actually had to treat somebody with this before. And the methods for this was a literature review on 3 different databases for the clinical information outside of the 2 cases. Published literature describes an heterotopic pregnancy as a rare occurrence when you have a simultaneous intrauterine and ectopic pregnancy. The incidence is 1 in the 30,000 spontaneous pregnancies, and if the pregnancy was achieved with artificial reproductive technology, or ART, that does significantly increase to about 1 in 3,900. Both cases I'll present today have, one with a normal spontaneous pregnancy and one where there was artificial reproductive technology in use. And because it is hard to diagnose heterotopic pregnancies, that can sometimes be devastating with the mortality rates to the mom, but it's relatively low. It is 0.5 per 100,000 live births, and that would be if there was some sort of hemorrhagic shock with a fallopian tube rupture from the concurrent ectopic pregnancy. For case number 1, this was a 25-year-old G1P0 at 6 weeks with a positive pregnancy test. She came in with pain and vaginal bleeding. She had an ultrasound done that showed a gestational sac, but no fetal pulp, but the yolk sac was visualized, and neither ovary was visualized, but they didn't see anything at that time like a mass or free fluid. So they were considering a missed abortion or an early intrauterine pregnancy. The HCG was 380. And then 4 days later, she was coming in with the same complaint, and with her continued workup, her HCG rose to 783, and the IUP was continuing to regress. She continued to be trended with a rising HCG, and eventually they saw a hemorrhagic cyst in her right ovary, and the left ovary was normal. There was no free fluid. And then she was admitted for a myomectomy and XLAP, and they found an right ectopic pregnancy at that point. And it was in the cornea of the uterus, and they weren't able to see it on imaging due to the large fibroid. And then this is a picture over here showing her at the time of that surgery, and she just happened to have like a myomectomy that was needed from those fibroids, but they saw the right corneal pregnancy then. For the second case, she's a 36-year-old G1P0010, and she was coming in for an ultrasound after an IUI, and she had a beta HCG level, and as they were following it, they found a fetus A with a crown rump length at 9 weeks 1 day with an appropriate fetal heart rate, and then that was the intrauterine, and then ectopically in the right adnexa, they found a crown rump length of 7 weeks 1 day, appropriate fetal heart rate. But during this ultrasound, she had no free fluid in the pelvis, and her cervix was normal. And they saw in the right ovary likely a corpus luteal cyst, but the left ovary was unremarkable. She was stable, and since it was not ruptured, she was able to do conservative treatment, and they did potassium chloride injection into both gestational sacs. The results of this is that the heterotopic pregnancy, you want to talk about the risk factors, which would be previous ectopics, pelvic inflammatory disease, because you'd have scarring and hydrosalpinx, potential abdominal adhesions, and the use of artificial reproductive technology. For case 1, there is a reason why the ectopic was not visualized on transvaginal ultrasound due to the obstructing fibroid. And then for case 2, there were smaller fibroids, but that probably did not contribute to her ectopic pregnancy within her ovarian adnexa, but she had the risk factor of artificial reproductive technology. increasing her eggs that are ovulated, and the chance of improper implantation inside and outside of the uterine cavity. For conclusion, it's always a good idea if the patient's having symptoms to do an early pregnancy ultrasound to diagnose an IUP, but it's hard sometimes to, if you have obstructing views of the bilateral adnexa, to say, okay, cool, you have a IUP, but can we rule out anything fishy on the two adnexa? And then case 2 emphasizes the importance of thinking about prior risk factors such as prior abortions, fibroids, and IUIs. And we want to maintain a high index of suspicion when treating patients for spontaneous abortion, and to make sure that the beta HCG is appropriately trending down. And then these are my references.